Okay. Welcome, everyone. My name is Barbara Cochran. I'm the director of the Dentistry Center for Healthy Aging here in the School of Nursing. And as usual, today I am representing the Northwest Geriatrics Workforce Enhancement Center, which is sponsoring this geriatric healthcare lecture series. I do want to remind you again to contact your site coordinator if you have not filled out a profile form for this term series. We use that information to report to our funding agency, all de-identified, but it's how we're able to continue to sustain this lecture series from term to term. And just a reminder that we will be having another series of 10 lectures starting March 28th, same time. And that will cover lectures specifically focused on dementia and Alzheimer's disease and related dementias. Today, however, I'm happy to introduce, and I'm going to try to pronounce this correctly, Suzanne Charlotte Jeffrey, yes, who is a lecturer in oral health sciences. She is a general dentist with additional postgraduate training in immunobiology, neurobiology, and geriatric dentistry. And after completing an internship in general dentistry, she's worked both in public and private dental care and with oral assessments, hygiene instructions, and dental treatment of geriatric patients at elderly homes and nursing homes. She came to UW in 2005 as a Ruth Kirstein Fellow in Salivary gland biology. She's the main instructor for geriatric dentistry at the UW School of Dentistry, and she directs the Senior Center Geriatric Dental Clinic, where she and the fourth-year students provide dental care to low-income elderly as part of the school's geriatric dentistry curriculum. She also loves seeing her own patients, both young and old, in the UW School of Dentistry faculty practice, and she brings tremendous expertise and a lot of resources today, as you've seen. So welcome, Dr. Charlotte Jeffrey.
Thank you. Thank you. Okay, so it's a pleasure to be here, and I hope that I can bring the expertise that you need. I have been both in basic science and in clinic, both in public and private dental health, and let's get started. So when it comes to geriatric oral health, the main issue is actually the chronic diseases and the medications. Usually aging per se doesn't bring any drastic changes, at least not until you are in your 80s or early 90s. But it is the chronic diseases and the medication that produce the dry mouth or oral dryness or xerostomia that is the problem for your teeth.
I need to click on the...
So now we are trying here to advance the slides. Let's see here.
There you go.
Okay. So here are some facts about older adult oral health. I think, as you all know, by 2060, like 1/4 of the US population will be 65 years or older. And I think 1/5 of our population will be 65 years or older, even in like 2030. So that's so much closer. What is troubling in terms of teeth is that many older adults or older Americans don't have dental insurance. Usually we lose our benefits upon retirement, and the Medicare problem here in Washington State called Apple Health doesn't cover routine dental care. So some of my slides might be hard to read, so I will be so happy to send you a PDF file of, so you just need to request that through Barb. Here is the Apple Health or Medicaid coverage for adults or for seniors like 65 plus. And as an example, it covers root canals on anterior teeth, but it doesn't cover root canals on molars, which in terms of chewing is much more important than the anterior teeth. And it also covers a cleaning like once every 3 months. Sorry, once every 12 months. But when you get older, you might need more cleanings than that. So it covers temporary dentures or temporary partial dentures, but it doesn't cover the ones who are more stable and made out of cobalt chrome and resin. So it is not a very good dental coverage if we compare the Apple Health to international standards. So if you look at the US population, we see there are about like 10% of the US population that are missing teeth totally, and about half of the US population are missing at least one tooth, and that is not including the wisdom tooth. So I'm 58 years old, and about half of Americans wear full or partial dentures in my age group. So this is kind of frightening when you look at it. So I think we have a lot to do here and learn in terms of preventive care. So if you look at tooth loss, and you can see that some teeth have fractured here, and there is caries and root caries on many of the remaining teeth. So tooth loss comes as a result of caries, or mostly caries, and also some from periodontitis. And most people that are edentulous or belong to the most vulnerable populations, the aging population and the ones who cannot afford dental care. So together with our fourth-year students, I work with both of those populations. So they get dental care for free, and everything we can do in the clinic, they get for free. So in terms of how missing teeth, how it affects your overall health, it is also associated with some forms of cancer. So ovarian cancer, if you have hypodontia, but that is due to genetic mutations, then you have, you might develop ovarian cancer to a higher percentage, about, I think 20% of ovarian cancer patients had hypodontia. But otherwise, when you are starting to miss teeth or have spaces in your dentition. It's easier to eat not as healthy food, to get obese, to get diabetes, develop coronary artery disease, and so forth. So which groups are the most vulnerable in terms of dental care or in terms of their dentition? So of course it is the homeless elderly, and especially those with mental health issues, and also dependent elderly with dementia. Community dwelling elderly, which I work with every week, they are fine as good as they have a strong support group. So I run a dental clinic inside of a senior center, and that works perfect because you need the contact with social workers or strong family members in order to take care of yourself, and you see it on your dentition if you do not. So I made some examples from the Apple Health chart that was hard for us to see, and here it is more in written form. So here is an example that Apple Health, it doesn't reimburse root canals on molars. I said only on one rooted teeth. So that means that for elderly, it's so much cheaper and easier to just extract a tooth. At the School of Dentistry, the students charge around $100 to extract a tooth, while the root canal is in the range of $1,000. So it's an easy decision for most elderly to just extract a tooth. As a result, though, we get really complex cases when it comes to rehabilitation, if it all is possible, because the elderly lose their vertical dimension. The bite kind of collapse. And as a result, the chewing capacity decreases tremendously. In order to restore that, for pain patients where I do that in the faculty practice where I also work, you might need both orthodontic treatment and surgery. And of course, this is not an option for most elderly, and especially not for the vulnerable elderly. And here you also have in writing that Apple Health only reimburses all rest and partial dentures, which we can also call temporary dentures, or temporary partial dentures, which is not the best quality. So I'm going through all of these disparity and bad news just to kind of set the context in which geriatric dentistry exists for the moment here in the US. So NIH have started to update their strategic plans, and they have finalized some goals. So they want to support more scientific studies to improve dental, oral, and craniofacial health in the US. And they also are willing to support multidisciplinary research approaches just to overcome disparities and the inequalities that you see in dental, oral, and craniofacial health. So this is very encouraging. If you look at oral health globally, the World Health Organization has an oral health goal of 20 teeth, and that would mean like premolar to premolar. And in order to achieve that, we need to have great preventive care so we can prevent caries, which is the main cause of tooth loss. I would like to see a treatment goal where we preserve and maintain the whole dentition throughout life, like teeth for life. And in order to do that, we need to help patients to have a higher self-esteem, to care about their oral health and reduce oral health or have a better access to care. It is really difficult for elderly to have access to care, especially if you're in nursing homes that don't have a dental clinic. I have patients that email me and want to see what resources we have for them to get free or cost-reduced oral health or oral care. even if we can restore the dentition, there are scientific proof that the length of tooth survival in oral adults is actually reduced. So if you start out with a poor oral health at the first exam, and this is a study from Minnesota, and it's community dwelling elderly, if you have oral health at the first exam, the participants, they continue to lose, or 20% of the participants continue to lose teeth within a year after the existing condition were treated. So that means that it's hard to help our patients to kind of turn around, to change their diet, to change their oral habits in order to stop the caries process. And we need to put a lot of work and effort into this. And also, once you get dentures, dentures are very plaque accumulating. So we need to have lots of follow-ups and preventive care to prevent further loss of teeth, also in that population. Here is an image or a photo of the Senior Center Dental Clinic in Snohomish County. It is in Linwood, Washington State, where we see patients every Friday and they get free dental care. And we also go to Longview 4 times per year and give free dental care, and we use the housing authorities room, and we can just set up a clinic over the day. And together with the first and third year students, we actually also use the mobile equipment for the 10th city residents now, just in February, and we will do it again in March. So there is a lot of need for dental care and to improve the dental health of elderly and also other disparity groups. So this was just the introduction, just so you know where geriatric dentistry is for the moment. So what I want us to learn today is I want us to see what normal oral aging is and what makes the aging changes go faster. So I want you to be able to, after you have been with me for a bit more than an hour, to describe how you can compensate for the effects of medications, and also to provide preventive oral care for community dwelling elderly and also for elderly in assisted living facilities. So if we look at the oral function in the elderly, now you have the oral mucosa, which can be dry. You have salivary flow that affects all of the teeth, and it contains fluid, water, and affiltration of plasma, and proteins and glycoproteins, tiny peptides, enzymes, everything that is important for the health of the mucosa and the teeth. We have a lot of sensory input. We have a lot of sensory nerves in the oral cavity. And what can also be reduced, especially in dementia patients and in Alzheimer's dementia, is the swallowing process. We have taste buds that needs to be maintained, and when we age, we don't feel salt as early as we used to, and we also have an increased threshold for sour taste. What also happens is that the bone height is reduced, and that is especially important for the mandible. So it's important to keep the teeth in your lower jaw, because you might not be able to have a complete denture or full denture that sits well. And we also have some aging changes in the gums and in the periodontium. So we are able to actually check the saliva. There are kits that you can buy, and I will also show you a simple method that you can check it yourself. So what we are doing now with the elderly, just to see in what kind of risk zone they are, is to check the pH of their saliva, both the unstimulated and the stimulated, and also how they are able to buffer if they eat acidic foods, which everyone does. And this is important just in order to keep our teeth as long as possible. So what happens when we age? Well, in the face, you can see it here. There's loss of volume. You can see it in the skin, but you can see here how the mandible really has lost its height. And I think you can imagine that the lower denture here has almost nothing to kind of grip onto. And for women that have had osteoporosis and maybe have been taking bisphosphonates, it's not easy to put implants either because they might not heal. So what you can see here is the loss of bone height and the thinning of collagen and elastic fibers in the face, and you also see that the fat is reduced. So what type of normal age influence do we have on the periodontal tissues? Well, if we look first at the young adult, you know, everything looks so shiny, nice. You have the stippled surface, very tight connection between the gingiva and the tooth, and the gums are firm. What happens as we age is that the oral mucosa becomes more thin, smooth, and really dry. The gingiva loses its stippling because these rated pegs here, if you look at the histology, they just flatten out. And we get a lesser like keratinization. So we get a thinner barrier, which means when we look at the immune system that we will have more frequent inflammatory lesions in the gums. And you can see that in the elderly because they respond to plaque more dramatically, and they have more bleeding gums than you do when you're younger. So you have chronic inflammations more often when you're older. You can also see that the capillaries decrease, the blood supply is reduced, which means that you heal lesser from extractions or surgery. So the immune response, and we said a bit of this just now, the gingival immune response is diminished, more inflammation, slower healing, and we usually collect plaque towards the gum line where we have the mucocutaneous junction, and we have an ineffective protection just there. And also if you have a loss of saliva, you don't have the antimicrobial peptides in saliva that will protect the gingiva as well. So this means that we have a more rapid and severe development of gingivitis. We have less of antigen presenting cells, and you have a lot of these dendritic cells in teeth. So that also means that teeth are, you develop deeper lesions much faster when you're older. If we look at the mechanoreceptors, and for you who might remember from your histology, Ruffinis, or they are encapsulated. So I've taken two examples here, the free nerve endings and the encapsulated ones. Ruffinis are in the periodontium, and they decrease in number, so that means that it's hard for an older person to feel how hard you bite. So that also affects the motor function and your chewing capacity. And the free nerve endings, we have a decreased sensitivity. So when you treat elderly patients in the dental chair, they might call you up the day after and tell you that they have been so bruised and it's hurting so much, but while they are in the chair, they don't feel it. So they don't feel when it hurts until it has turned into a more severe wound. So I said that we had a lot of sensory innovation, and sensory nerves with lots of different trip channels for cold temperatures, hot temperatures, nociceptors and touch. And of course this also ages. So in normal aging, you are not as sensitive to different types of temperatures. And I said before that we have a higher threshold for salt. Saliva actually contains more salt when we get older. So it's harder for us to say that food is salty because we can tolerate more. And we also have a higher threshold for sour taste, which is not that great for our teeth because, as you know, that acids, it demineralizes the teeth. Okay, so what happens with the saliva? Well, the acinar cells, which are the ones that transport the fluid from, or the filtrate from the capillary network to the salivary ducts, they decrease with age. So we lose about 20 to 40% of our acinar cells. So, but it is with medication that you really feel or develop a dry mouth. So in normal aging, you can feel a reduced salivation, but you can live with, you can compensate by drinking a lot of water during the day, so you might not be aware of it. So the saliva comes from the major salivary glands, and we have three, as you see here. They are paired. It is the parotid gland, which is more active when we eat. And then you have the submandibular and the sublingual glands, and they are more active during, or they have a higher percentage of the total saliva during unstimulated secretion or resting. And this type of saliva from these glands are more slimy or more mucus, and they lubricate the mucosa more than from the parotid gland. The parotid gland is more, as I said, is more active like when we eat, and it contains more of the digestive enzymes. We also have a lot of minor glands, and you can see them here. The mucus glands, the yellow ones, are in the palate, and that is great for retention of complete dentures. Then you have the serous glands that have a more like watery secretion, and that also contains lipase for digestion of lipids on the dorsal part of the tongue, and then in the anterior part of the mouth and on the anterior part of the tongue you have these mixed ones. So in the cheeks and on the lips and on the anterior part of the tongue you have all of these green ones here that are mixed, both serous and mucus. So when you look at the saliva, and if we are interested in what type of saliva that decreases with age, you see that it is the resting saliva that we get less of. And let's say we only eat like 2 hours per day. So the rest of the time, like the rest of the 24 hours, we can feel really dry. And you see here that the parotid gland, it contributes to 50% of the stimulated saliva, but just 20% of the resting saliva. So it is the saliva from these glands that is really important. So how can we stimulate the saliva? Well, that's why in nursing homes it's important to have good meal times and food that looks delicious and also that smells delicious and tastes delicious, because all of that is part of stimulating saliva. So you have it from the taste buds and the masticatory stimulus, which means that it's actually better to have your own teeth than to have lots of implants. Because when you have implants, you don't get the stimulus from chewing that you do from your normal teeth. And also from the smell of food, but also from the hypothalamus, gets activated by daylight, which turns on the salivary glands as well. So the salivary glands are part of the circadian rhythm, just as many other tissues and organs. And we know more now than we did in 1974, when Dawes was doing his first studies, and he was seeing that we actually had a circadian rhythm in terms of the different ions that was secreted into saliva, and it was both for unstimulated and stimulated saliva. But recently we know that we have the same type of clock genes that, like BMAL and period, also in the salivary glands. So this is just a biopsy taken from a young female's salivary gland, and that has been stained for one of the clock genes, and you can see that it's positive for all of the nuclei in the acinar cells and in the ducts. So the salivary gland is directed by the circadian rhythm and by the hypothalamus. You can override that direction. But some of the proteins that are secreted are also secreted at a circadian rhythm, more during the day and then resting at night, while others are independent. And that is where our research is right now. So this doesn't look that encouraging, does it? This is mostly a picture that you would find in nursing home patients. So here you see that the crowns are gone on the teeth, and you just have the dentin, which is really soft. It has the same softness as bone. Here in this older woman, you see that you have calculus down on the root surfaces, and here you see an ill-fitting denture, and the patient has just eaten, so you can see there's lots of food that came in between the arches and the denture. So how can we prevent this? Well, first we need to know what type of flow we have, what type of pH we have, and what type of buffering capacity, and what type of proteins and glycoproteins in saliva as we age. And this is where our knowledge for the moment is actually rudimentary. We need more basic science research regarding saliva quality in older individuals, and that also take different medications. So what happens in the salivary glands that affects the teeth and the oral mucosa during aging is that the flow is dependent, of course, on the aquaporin water channels. It's similar to what happens in the kidneys, except we have different types of aquaporins. Here it is aquaporin 5. And these aquaporin channels that are dependent on, first, the cholinuric stimulation, which means that if we take anticholinuric medications, we diminish the flow. They're also testosterone dependent. And as females grow older and we lose the ovaries, and we might lose aromatase, we might have a harder time to convert estrogen or DHA to the different androgens that are needed in order to activate or upregulate the aquaporin water channels. pH can also be affected in aging, and that occurs. The regulation of the pH occurs in striated ducts. So this is part of the ductal system in the salivary glands. And both the pH and the buffering capacity is dependent on aldosterone, which is secreted from the adrenal gland. So if you have adrenal fatigue or if you have problems with your adrenal gland, that can also affect the pH of your saliva. And the proteins, they are secreted here from the acinar cells, like in the lower part of the tree, and they are dependent on the adreneric stimulation. So if we take anti-adreneric medications, we have a lesser protein secretion. And the glycoprotein secretion, the mucins, they are dependent on the cholinergic stimulation. So you see here how different medications can affect saliva secretion, or different parts of saliva secretion. So recently it has been known that older, or as women age, we lose the estrogen from the ovaries. So we need all of the DHEA that is secreted from the adrenal gland, and that can be converted by the salivary glands. But if you compare it to males, we have much lesser sex steroid supply. So females tend to be more drier just normally than males are. First, it was only known for rats, but it's actually also true for humans. So normally in salivary glands, we have a lot of sex steroid converting enzymes that are located in the acinar cells, or in the plasma membrane of the acinar cells, in the intercalated ducts, and also in the striated and the more excretory ducts. And this knowledge was actually, or the paper that added this knowledge came out in 2009. So that's just like 8 years ago. And we have still rudimentary knowledge when the localizations of these sex steroid converting enzymes are aberrant, but we know now that for Sjögren's syndrome, like the dry mouth disease or the autoimmune disease, the enzymes that convert DHEA to the androgens and estrogens needed for salivary gland secretion, they are missing, or they are lacking. And there are also some dysregulation of the ones that are normally present for the acinar cells. So if we look at salivary gland secretion with aging, there's usually just a flattening of the circadian rhythm, which means that here you can see the normal like sinus or cosinus curve, and it just means that we don't secrete as much. And you can also see here that we secrete more at the afternoon every day when we have more daylight, and we secrete less when we sleep, when it's dark. So taken all together here, do we have any changes in saliva secretion during normal aging? Well, that has been an academic question for so many years. And all studies taken together, yes, we do have a reduced flow rate. There were 2 large studies during the year 1998 and 2000 that finally agreed and said, yes, we do. So are there any changes in composition of saliva? And this is as much as we know right now. We have less of mucins. And that is important since mucins, they aggregate bacteria, they form the pellicle around the tooth or on the tooth surface, and it also protects the oral mucosa from dehydration. So that is why you feel more dry. Even if you don't have xerostomia, you just feel more dry. And here is mucus acinar cells, and you see the secretory granules in which the mucins are packed, and they will then be secreted, and it is the cholinergic stimulation that causes that. There is also one more protein that decreases that we know of right now, but we also need more knowledge about this, and it's the Cystatin 5. And that is important in order to protect us from Candida infections. So that's why older individuals usually have more Candida infections. These photos are from a younger individual, as you can see here. But Candida infections in the oral cavity, you can usually see it in the palate and on the tongue. And here you can see these red areas here that shows that Candida is present on the tongue. And here is more looked like just a tiny part of the tongue is affected. And what happens is that Candida eats all the keratinization that is part of the filiform papilla that is here, located here on the tongue. So you can see that all like the grayness here, the keratinization is gone. But with nystatin or antifungal medication, that can easily be restored. So I will present to you later or at the end of this presentation just a scenario and how you would treat it if you have a patient that also wear dentures, because it's not enough to give a rinse or lozenges. You need both the ointment and the rinse in order to heal that. And the third question, do we have increased oral dryness with normal aging? And the answer is yes. All studies taken together, up to 50% of individuals suffer from oral dryness, and women more so than men. And now we know that is probably because of the lower estrogen levels, or if we have mutations in the sex steroid converting enzymes. So everything taken together, we said that we had a lower salivary flow due to we didn't have as many acinar cells in the salivary glands. I said about 20 to 40% less. We had the flattening of the circadian rhythm, so we don't secrete as much. The cosinus curve is lower. We have changes in the protein composition, less mucins and less histatins. And if we have subjects that have a subjective oral dryness, they just feel dry, you usually have a lesser fluid secretion, and this means unstimulated saliva fluid. And we also see that these individuals have a lower level of these antimicrobial peptides, like lactoferrin, lysozyme, for example, in saliva. So how does that affect us? Well, everything taken together with aging affects the masticatory performance, as you can say scientifically. And that means the ability to break down foods, and the number of chewing cycles are higher just when you chew a standardized piece of food. And the factors that affects the masticatory performance is the loss of posterior teeth. So when we need more than premolars, we need the molars to still be present. Tooth wear, it comes through grinding or eating a lot of acid foods that demineralize the tooth surfaces. Occlusal force, we get less occlusal force with dementia, for example, or also with aging when we don't feel how hard we need to bite. The salivary flow is really important. And the oral motor function also diminishes with aging. So altogether with aging, we get a lesser masticatory performance. Okay, so we have medications that have high dental impact, and I think I've already mentioned them. We will not go through the signaling system within the salivary gland, but I just wanted you to see how complex it is. So I made 4 different, stations here for this cell. So the first thing that is important, it is here that we can, and it costs a lot of ATP, it costs a lot of energy to set up a gradient where sodium is transported out of the cell. And that kind of starts the whole secretion so that sodium and chloride can get back in again and then get secreted through the calcium-dependent chloride channels here, and water can follow. But you can see how sensitive this is. You have the beta-adenuric receptors, the alpha-adenuric receptors, and the cholinuric receptors, and with beta blockers or calcium channel blockers or anticholinuric medication or diuretics, you get a dry mouth immediately. So here are the most important steps for saliva secretion, and here are just a very short list of the medications which affect saliva flow the most. So I was talking to one physician, and he was saying, "Oh, aren't you happy now because we are getting rid of the beta blockers and we are using calcium channel blockers instead?" And I said, "No, because it actually affects saliva secretion more." So in order to get both proteins and fluid out of the cell, you need calcium. In order for these granules to even merge with the plasma membrane, and in order for these channels to open, you need calcium. So if you block the calcium flow, you block both protein and saliva and fluid secretion at the same time. Here are just some examples of what saliva contains. It contains I think it is over 1,000 different small proteins or peptides. It is 99.5% water, and the rest are those peptides and enzymes. We also have some gases. We have some buffer system. We have a phosphate-based like buffer system and bicarbonate-based buffer system. We have different enzymes that digest food. We have some antimicrobial enzymes, lysozyme, lactoferrin, histatins, defensins, and some of these are actually incorporated into the old version of biotin. So that's why biotin is helpful. We also have some growth factors, and you can see here, if you look at this blot here, that different salivary glands secrete different types of proteins. So saliva is different depending on what gland it comes from. So if you want to test your saliva yourself, or you can first look at your hydration just on the inside of your lip, and if you form a drop of saliva within like a minute, you have normal secretion. And then you can test the unstimulated saliva using a kit, where I will show you a very inexpensive way later, and also stimulated saliva. And then there are some tests that you can buy where you can see how much of Streptococcus mutans you have in saliva. And we have done this when we started the new curriculum for the dental students. For the last 2 years, we have gone through the saliva test with them, and we realized that most of us are positive for Streptococcus mutans. So that test is not as powerful as just to look at the quality of your saliva in terms of pH and buffer capacity. And here is what it would look like. It contains just just a visual scale, so you can determine the pH of your saliva. There are these pH strips. You chew on paraffin, and you can measure the amount using these medicine cups. But it's actually better just to weigh the saliva and to approximate 1 milliliter to 1 gram. And here are the buffering strips. And I know that this doesn't look like it comes out that great, but I was just doing it on myself just to show you. Here is my resting saliva, and you need to measure for 5 minutes to get a reproducible result. So my flow rate for the rest thing is points seven milliliter. Per minute and my rest saliva the pH is around 6 point date. And here is if you do the stimulated secretion, you should do on paraffin. It doesn't taste like anything. You can see how much more you form. So the flow rate here for me was 1.6. 7. And when you weigh it, you get it right away. And then you see I have a much higher peak pH. On my stimulus latest saliva. And then when we check for buffer capacity, in on these strips there are different acids that are dried into the strip. this shows that I have a high to normal buffering capacity. So even if I eat the acidic foods, I can buffer back. The pH on my saliva, even if it's things first. Or if it drops first, I can buffer it back. To normal within .30 minutes. And here is strep. Streptococcus mutans. Test is an antibody test is much more expensive. expensive. And since we saw that most of our students with the meticulous oral hygiene. had too much streptococcus mutant growing I have stopped using it as much, but it is commercially available and it might serve as a good Reminder for the patient, or they can see that they have too much of bacteria growing in their mouth. And that can be beneficial for having them turn around and put some more effort into their hygiene. So here is a scale that I made where you can see where your result fits in. So the green part here is normal results, or normal results. So every minute in resting you should secrete about 0.25 milliliter, and the pH of your unstimulated saliva, mine was 6.8, but you see here is still healthy, and stimulated saliva about 1 ml per minute is healthy. When it comes to the more moderately acidic, this is where it starts to affect your teeth, and especially here in this unstimulated saliva in this pH range, because it affects your root surfaces. I will show you some photos or some radiographs of patients here. And first you can see how the dental students, how they did. And this is me, Dr. Jeffrey. You can see that they have a higher pH in the resting secretion than I have, but I'm older. They also secrete more per minute. We are the same in pH of the stimulated secretion. So the stimulated secretion, it doesn't fluctuate as much as the unstimulated. And we also both have high in buffer capacity. And most of the dental students were positive. They had too much strep mutans in their saliva. So what about patients? If you look at an older patient that is high caries, one of my patients, here she didn't form. Even she didn't have hydration, and not my diabetic patient, or one of my diabetic patients either. So you can see here the early signs. They don't form that from the mind. They don't form that drop of saliva within a minute on the inside of their lips. You can see also here, they secrete less than 0.1 milliliter per minute. So they are really dry in their resting secretion. And that's the type of secretion that you would have here and now, like when you're sitting and listening to me and not doing much. And they had a lower pH. So I will show you a slide in a while that shows you that root surfaces, they demineralize below 6.7. So this is what this means, that normally during 22 hours of the day, they have a saliva that kind of demineralizes their teeth automatically. So that's why root caries is the worst enemy and produces tooth loss. You can see that their stimulated saliva is also affected. And of course, for the one patient that we were testing the strep mutants, she was also positive. And here are some radiographs of one of the patients, the one here, the high caries risk patient. And you can see here right underneath the crown margin is where you see it's darker, and that means that there's a demineralization. It might not be a cavity yet, but most probably. And here is where it will show. The crown will be okay even if you didn't have a crown on. If you just had enamel, it might be still okay, but it is the root surface that cannot take this low pH. You see also here, we call it secondary caries, and it has come right underneath where the filling is. Here you see it's a different angle of the x-ray. So you see it looks like a mouse have taken a bite of a cheese. Right there and right there. So this is where you get root caries when you have low unstimulated saliva secretion that has a lower pH than what your root surfaces can take. This is a younger diabetic patient. Her values are as bad as the older individual, but we don't know. With these tests, we don't see what saliva contains. So for her, the scenario is not as dangerous. There is some demineralization here. Right underneath that filling is a dark line. So for her it's more, and this is a screenshot of all of the caries that are registered. So she has primary caries on some teeth, but she has just started caries, incipient, on many. You know, there are over 10 of them. And secondary caries, and then I said watch for decay. So they might not have fully developed yet, just because she might have more antimicrobials in her saliva than the older high caries risk patient. And this is her in 2015. And I don't see that much of a change. I redid that filling. There is still that demineralization, but I also used a lot of fluoride varnish. We have gone through diet changes, and I put silver diamine fluoride on her teeth. So she's actually holding up, although she has very low values here. But you see, she still has incipient caries, more primary caries, and as I watch for decay. So here, this has been able to slow down with the changes we have been making. So, will a patient ever tell you that she feels dry in her mouth? Well, most of my patients say, no, I'm fine. So then you need to continue to ask them, do you drink a lot of water? And they will usually say yes. So here are some questions that you can use just to find out how dry patients are. Like dry when you're eating a meal, you need to go up at night to drink, or you have problems eating dry foods. And this is the most dangerous thing. You need to suck candy or lollipops just to relieve the dry mouth. If it is xylitol, lollies, that's okay. But if it is sucrose, that's not that great. But this is how you can see if your patients have a dry mouth. You can also get a reduced flow as a result of disease, and you can see that all these affect the acinar cells. So in Sjögren's syndrome, which is an autoimmune disease, and in lupus and in graft versus host, all of these are autoimmune diseases where the acinar cells are destroyed. So of course you get a reduced flow. And also through radiation to the head and neck, if you ruin or destroy the stem cells, you also get less acinar cells, and of course you get a lesser flow. But usually, and I think you have picked up this now, it's as a result of the different medications we take. And this is how it can look. But this is when you are really dry. You see the keratinization is gone, as if you had candida. So if you have a dry mouth, it's very easy, of course, to develop a candida infection as well. You see the dryness on the lip, and just the redness and the dryness on the tongue. Here, the black parts here might not be soft. They are called chronic caries. And you see that they are at the gum line, and that's where the root surfaces are. So enamel is usually okay, but it is the root surfaces that demineralize at a much higher pH that are affected. And then you have the pigment that kind of gets incorporated if they harden. So that's why it looks like this. And here is a simple investment. For $20, you can do this at home. You need a medicine cup, and then I bought this on Amazon. This is a pH strip, so you can measure your unstimulated flow and your stimulated flow. You just need some paraffin to chew on for the stimulated, and then you just need a food scale. And then you can weigh your saliva. You need a tare function so that you can zero it, and then you can inspect, of course, the minor gland secretion, and you can measure the unstimulated and the stimulated. So if you or your patients have a low flow and a low pH, you need to be very careful with the oral hygiene. So how do you help with oral dryness? And what I'm going to show you now helps more with the effects of mucosal dryness, because it can really hurt. So this is not an artificial saliva. This type of spray came out just 2 years ago, and it is the only one in the Cochrane review from the UK that made any effect on a visual analog scale, and it made a 2-point difference. Biotine, they didn't make a difference at all, or chewing gum, they didn't make a difference, but just the feeling of oral dryness towards the mucosa. And this is an